patient. Proper patient positioning is very important for a safe, smooth, and successful endoscopy. The patient should be positioned in the left lateral decubitus position with the head of the bed elevated. After dental appliances are removed, an appropriate numbing spray is applied to the patient's oral pharynx. A bite block is secured in the patient's mouth. This allows the scope to freely move through the oral pharynx without being obstructed or damaged by the patient's teeth and jaws. Ensure that the patient has supplemental oxygen in place and that the intravenous line has easy access for medication administration. The tip of the endoscope is placed in the patient's mouth. The big wheel is then pulled back to allow the scope to follow the natural curvature over the patient's tongue. At the base of the tongue, the epiglottis comes into view. The tip of the scope is passed posterior to the epiglottis and placed at the cricopharyngeal muscle. The endoscopist applies gentle forward pressure while asking the patient to swallow to assist with passage of the scope into the esophagus. A long view of the esophagus is obtained. One can often identify a point of narrowing at the aortic arch crossover. The Z-line is evaluated at the gastroesophageal junction. A scope is then advanced into the stomach, which is fully inflated with air to allow for a complete examination. Once adequate examination of the stomach has been attained, the scope is then advanced into the antrum and the pylorus is identified. Gentle pressure at the pylorus while keeping the lumen in view will assist with passage of the endoscope into the duodenal bulb. The scope is then advanced into the first portion of the duodenum. The maneuver of pulling the large wheel back and pushing the small wheel forward while rotating the control head to the right will assist in passing the scope into the second and third portions of the duodenum. The duodenal mucosa is then inspected as the scope is slowly withdrawn into the stomach. Once in the stomach, the antrum is able to be further inspected. The large wheel is then pulled all the way back to allow for retroflexion and examination of the gastroesophageal junction and fundus. Withdrawing the scope with rotation left and right will help with further evaluation of these areas. The scope is then straightened with the tip placed back into the antrum. Antrum biopsies can be taken with the biopsy forceps as it is passed through the working channel. Multiple biopsies can be taken at one time. Here we see normal waves of peristalsis as they pass by the incisura. The scope is then withdrawn into the esophagus. Biopsies of the distal esophagus are taken in a similar fashion to those taken in the antrum. Once completed, the scope is placed back into the lumen of the stomach, which is then decompressed, and the scope is withdrawn from the patient. Endoscopic skills are an important asset for every general surgeon. We have reviewed the components essential for a safe and successful basic upper endoscopy. These include endoscope setup, endoscope controls, room setup, patient positioning, and the proper technique of an upper endoscopy.